So, question that has recently been proposed is what would a lumbar spine evaluation look like? And if one was looking at that evaluation through the lens of mechanical diagnosis and treatment and/or McKenzie approach. So, in a very streamlined, bulleted format, this is as of the last MDTA Part A, that is course that I've taken, which focuses on the lumbar spine. The physical exam includes sitting, standing, movement loss assessment, movement testing. This is where you get more into the quintessential elements of the mechanical diagnosis and treatment, where you go into repeated movements. So that kind of progression and protocol for the evaluation, we'll call it a standard operating procedure, is done where for the movement loss, there's perform a single repetition in each plane, simply noting any range of motion loss relative to what would otherwise be expected from normal. In certain instances, such as the side glide, you could look at a displacement of navel from left versus right and identify any potential lateral shift that otherwise would be present and/or mechanical block. The patient may offer symptoms in response to that correspond to that movement loss. The movement testing protocol is done a little bit differently. So you can see you start with flexion, you start with standing, you go with flexion first, repeated flexion, then extension. And the things that you're looking for here, so you can see the comment in the right-hand column. If I blow this up, potentially that's a little bit more clear. So determine the starting position, being standing, sitting, etc. Ask the patient to get into the starting position, establish a clear baseline of symptoms and movements. Patient performs 1 repetition, what happens during said movement. Patient performs 10 repetitions, monitoring for symptoms. It's recommended that they cycle a breath at the end range of position, as well as just a momentary pause when they restore all the way back up. Your observed mechanical responses, are they getting further? Are they is their range of motion getting less? After the repetitions, you're reassessing for symptom intensity and location versus baseline. Check other movements for mechanical changes. For instance, you may see that what was the movement loss initially has actually improved. That's why you take it first, and then you continue to explore and reassess. So that is the overall sequence of how to perform the repeated movements. Again, you do those typically in standing, lying, and then you go back to standing, where you explore the frontal plane rather than the sagittal. If indicated, you would do a neurological examination, neurodynamic static testing, where you use similar static positions and their response to that if needed, and other tests as indicated. Steps for repeated testing, as I had mentioned below, and then there's actual tips here. So I'll pause it here just so you can read over those. Great. And then this is an excerpt from page 93 of the 228 of the Part A course manual for the MDT. All right, so that is one resource. The other resource that would be valuable would be looking at the MDT assessment modified. That is my modification. So this is one way that that is the MDT providers structure it. So you have a pain scale where they're starting and where they end. You can see that they use symbolization: AB, down, up. AB is in abolish, down is in decrease, up arrow is in increase, C is in central, so on and so forth. And you would put that in accordingly. So like a check mark or increase or etc. And the symptom, and that's in correspondence with the symptom response. B as in better, D as in that's interesting. Sorry, that's incorrect. So B is in before, D is during, and A is after, and you would put in the corresponding characteristics or symbols and or abbreviations. And FIS is flexion and standing, repeated flexion and standing, extension and standing, repeated extension and standing. Same thing that we saw in the previous document. Another way that you could consider it, and the one that I typically use, is something like this, where you get the symptoms, and then you also talk about the mechanical response, is what happened to the range of motion, rather than just the symbolization that was used above. There is a mechanical response there where range of motion increases, or NE is no effect. And really what you're trying to ask yourself is, what category within the MDT model do they fit into? So this is derangement, dysfunction, postural, or other. And the classification typically follows this sheet here. So barring the other at the moment. So you can see the definitions for derangement, dysfunction, and postural. Obviously, MDT has been most notarized for its derangement. Within the what they've previously spoken about is the discogenic pathophysiology there. That model they've kind of backed away as far as their specificity as to whether that's discogenic is my interpretation of it, where they've emphasized more on just a directional preference, more so than specifying a particular disc injury necessarily. But I think that their previous model of the disc does hold up, at least based off the mechanistic studies that I've seen done in MRIs. And so that would grossly be how you would, and the general principles of how you would execute the MDT and repeated movement approach, as according to what I consider to be the authority, because they were the ones that developed it, would be the McKenzie and MDT certified therapists.